So now we're going to be diving into the huge chapter of neurology. The beauty of the chapter is that there's almost actually nothing new here at all. So it's a really big chapter as usual. You can see it's not really fitting the screen either, so I have to do the fifth page. Let me see how much I can zoom in. Just make it a little. Okay, there you go. So it's a lot. It's a lot of stuff. They also still have the eye in here, the ear topics under vertigo. So everything is here the same exact way that it was when we discussed these topics in step one. On top of that, now we're usually focusing on what is the test you order, how do you evaluate these patients, how do you manage these patients after they present with their issue, right? So thankfully, since majority of these things are in the brain, the ordering of tests is all usually the same, because you're only going to be really able to do like a CT of the brain, and that's basically it. If it's a vascular disorder, then you would do an angiography, right? And we're going to see a lot of the same trends, right? You treat the brain, when you're studying it, you treat the brain as an entire body of its own, just like you treat the rest of the body as an entire body. So the brain has its own limbs and organs and stuff like that, right? Inside the brain, you have your little different nuclei, you have your different little parts like the thalamus and the hypothalamus. So you really want to treat the brain as a whole human of its own, in a sense. A whole different organism of its own with its own different body parts, its own little anatomy, its own blood vessels, its own everything. And you break it down in that manner and you try to learn what each part does. Just like our arms are meant to grab things and our legs are meant to walk, you learn all the different parts of the brain and what those parts of the brain are meant to do. Because then you're going to get basic questions on, well, not basic questions, you're going to get questions on basic injuries that may have occurred in the brain, whether it was from a really bad car accident or someone hitting the person with a bat in the head, or a really bad fall from a ladder, right? Falling from the roof, falling from a tree, stuff like that. All of which can lead to different kind of hemorrhages, and then they're going to ask you questions about what's going to result. So that's what we're going to be diving into. Before we go into that, though, I wanted to look at one last thing that I saw over here yesterday. So there was this question in the book itself that I don't always do the questions that are in the book because they're very much like NBME almost. They're very unreal. So this one here says 55-year-old woman presents to the clinic with a chief complaint of blindness. She states that she experienced a temporary loss of vision in her left eye. She has also been experiencing new headaches and soreness in her jaw. Her vision exam is unremarkable, so she can see today. What diagnostic exam should be ordered? So when you read a question like this, every time you read this question, this is what you should say. So when you read that she has blindness, that's temporary, right? Temporary loss of vision in her left eye. That's temporary monocular blindness, one eye blindness. As soon as you read that in any question, immediately in your head you should say amaurosis fugax. This is amaurosis fugax. This thing right here. Right? And amaurosis fugax, monocular amaurosis fugax, is associated with giant cell temporal arteritis and may progress to complete vision loss. A temporal artery biopsy should be obtained, and of course you should start the patient on prednisone right away. So this question, the way it mentions amaurosis fugax by just telling you that she had temporary loss of vision in her left eye, this one little symptom of temporary loss of vision in the eye has so many different ways of occurring, right? We can even see this in multiple sclerosis, right, where the symptoms come and go. We can see this here, of course, in temporal arteritis, which was related to polymyalgia rheumatica, both of which were treated with prednisone. We studied, of course, that PMR is treated with low-dose prednisone, while the temporal arteritis is treated with high-dose prednisone because you really want to prevent this blindness that can become permanent. Great. Now, we see this amaurosis fugax thing here. There's another question that I recently found when I was doing the Kaplan QBank stuff with one of my students. So let's go look at that as well. And then we'll continue for today's lecture of neurology. Fibromuscular. Let's see. Okay, right here. So if you look at this question, 25-year-old woman comes to a physician complaining of transient vision loss in the right eye. Same exact thing. 6 months ago, she was told that her blood pressure was high at a local health fair. Her past medical history is otherwise unremarkable. She takes no medications. Grandma had a stroke at age 50. Blood pressure today is very high. BMI, pulse, they're fine. Exam shows a bruit below the right mandibular angle. Chest and abdominal exam were unremarkable. She has a 2+ lower extremity pulse. Labs give you a normal serum creatinine, very low potassium. Plasma renin is very high, and the aldosterone to renin ratio is 10, which of course probably doesn't mean much to you at all. Now, as usual, you still do the same thing though. When you read that, the patient has transient vision loss or temporary vision loss in one eye. That's one eye amaurosis fugax. Okay? But amaurosis fugax is not really related to anything specific. It's not specific for one diagnosis. It doesn't always mean that you must have temporal neuritis. It could be seen in any of these cases. This was the first time I saw it in a question about fibromuscular dysplasia though. But there were other cues in this question that were supposed to help you figure out its fibromuscular dysplasia. This is a very nice question in the sense that this is what UWorld does to kind of train you in picking on what's the important cue. See, by talking to you about the patient's main presenting complaint being transient vision loss, they really did a good job confusing the shit out of you, because now you're focused on that. Now you're focused on things that can cause transient vision loss. And we just listed 3, right? Now we know fibromuscular dysplasia, but we listed the other 2, which was the temporal neuritis and then multiple sclerosis, both of which can cause that. Here, by causing this to be the main focus of the question, they kind of made you stray away from what was actually happening, what's causing it. Now, of course, it's a question that has to give you the details you need to answer the question correctly, so they did give you what was key. They told you that her blood pressure is super high. Now, every time you ever read someone's blood pressure is super high, if it's not very evident why it's high, you should check the age, right? Never ignore the age. A 25-year-old woman having super high blood pressure, when we were in step 1 and we were studying hypertension under cardiovascular right after atherosclerosis, there were 2 things there. There was essential hypertension, which everyone gets, or there was fibromuscular dysplasia, which usually occurred in young women who had the string of beads in the renal arteries. But they further try to confuse you by giving you a bruit that isn't on the renal side of things, right? This is a bruit that isn't occurring on one of the sides of the aorta, where the renal artery would be. This is a bruit that's occurring in the right mandibular angle, which would be basically your carotids, right? The carotids are right under the mandibles. The last thing they did here that really helped figure out that this must be some kind of fibromuscular dysplasia was that they still had to mention something going on with the kidney. It wouldn't be kidney failure, creatinine is going to be normal, but it is a lot of renin secretion by the kidney because of the fibromuscular dysplasia messing up the renal artery, which of course messes up the amount of blood coming into the kidney. When the kidney is not getting enough perfusion, it releases more renin, right? And that's what they go on to explain in the rest of this question, where they ask the next best step, and of course you do a CT angiography of the abdomen to see the fibromuscular dysplasia, right? To see the string of beads that you're supposed to catch. And then on the left is the table that came with this question, which had all the other things. So usually they would give you an epigastric bruit on one or the other side, whichever side has the fibromuscular dysplasia, or possibly even bilaterally. And this is almost always resistant hypertension, where if she was even taking medications, it wouldn't get any better. Right, so there's a lot of ways that this can be tested. Even management is a big deal for fibromuscular dysplasia, because you have to do diagnosis, but mainly just follow-up. No real treatment per se. Right, medically treated patients need follow-up blood pressure and creatinine every 3 to 4 months, and a renal ultrasound every 6 to 12 months. So if you forgot about fibromuscular dysplasia and how it's managed in the clinical setting, that's your little shock study moment of just making sure you go back and check that to get it down. So now we dive into neurology. Let's take a look. So first things first, they go into the general clinical neuroanatomy of things. So like I was saying before a couple of you joined, that you want to treat the brain like a human of its own. When we were previously studying, we were studying everything down here, right? So we looked at every different organ system and all the different limbs and what all of it did. Now we're studying only things that are in here, the brain and all the main neurological connections with the eye and the ear, the tongue, So you want to cut that up into different body parts. You want to cut the brain up into different body parts, thalamus, hypothalamus, all the different nuclei, and study each one of their focuses and functions individually. Because you're going to get questions where the injury occurred in certain specific parts of the brain, and that has to tell you what deficit that's going to lead to. So here we're looking at spinal tract functions. Okay, so table 2.10, which is this one, -1 and -4. So we're going to look at -4 later. Highlight critical aspects of clinical neuroanatomy, including the clinical presentation of common spinal cord lesions, facial nerve lesions, and pertinent clinical reflexes. So the first thing they have here are your spinal tract functions, your lateral corticospinal tract, your dorsal column, which works with the medial lemniscus, and the spinal thalamic tract. The three main tracts that you need to make sure you have down perfectly without any real confusion whatsoever. You should be able to sit down and draw the tract on the human body, or draw the tract blindly without really having to look at the book. Now, to make that easier, this is something that, let me see what they have. I forget what I didn't look at this before I sat down today. Okay, alright, we're good. So we're going to try to do all these questions today too. So before we even look at anything else, let's get these tracts down first. This is like one of the primary things that you get tested on. Your lateral corticospinal tract is one of your descending tracts. It's for movement. It's something that comes from the brain down, tells your muscles to move. Movement of the same side limbs and body. Clinical effects of a lesion would cause same side paresis at and below level of lesion. Dorsal column medial lemniscus is for fine touch, and mainly the thing that we test for is proprioception. Can you stay standing still with your hands out if you close your eyes? And then be able to tell me where your hands and legs are. Ipsilateral, if you have lesion, then you have same side loss of fine touch, vibration, and proprioception at and below the level of lesion. Above the level of lesion is something different, because it's usually going to become contralateral there. The last thing here is spinal thalamic. All right, so remember, they're talking about spinal tract stuff, not in the brain, but on the spinal tract in your spine. The spinal thalamic, it's thalamic, which is for temperature. So this is the one that is another ascending fiber for pain and temperature. This is going to be messed up in people who, the syringomyelia people, because it ends up compressing this segment, and they can't feel pain and temperature at all. Contralateral loss of pain and temperature at and below level of lesion. Okay, great. So generally speaking, this is all not so bad at all. Now we can go back to the step 1 book to really get down the general pathways and memorize them as perfectly as possible. So here I have the main lesions, the main everything. This entire stuff is all discussed in the step 1 neuro videos that most of you should have access to, or all of you may have access to. Here we're going to first look at the spinal thalamic tract. So right here we have our spinal thalamic tract, which comes down, right? Goes up, excuse me. These are all ascending fibers. Goes up and tells your brain any pain or temperature changes you're feeling. So it starts from down here, right? This is when your ascending tract is going to be a sensory tract. Right at the spinal column, you can see it decussates, which is one of the most unique things about the spinal thalamic tract. It decussates immediately. See, most of these other, the only other one that would ascend is your dorsal column. These are both dorsal columns. You can see that the dorsal column doesn't decussate immediately. It goes up first, then moves over to the other side. Spinal thalamic tract is very unique in that it decussates on the same exact level. So it comes in via the dorsal root ganglia, synapses over here, and then decussates using the ventral white commissure, which is what gets compressed in people who have a syrinx. Syringomyelia, there's going to be a little syrinx here that's going to end up compressing on that nerve before it can even try to make its way to the other side. That means that it messes up both of them. There's obviously another one for the other side that is also going to come here and cross over, right, do this business, and then go up. Right, that's going to be for the right side. That one also gets messed up. So these people with the syringomyelia, they have bilateral loss of pain and temperature. So it crosses over right there, and then now it's going to start ascending. So what does it use to start ascending? Well, it's going to go up and use this very lateral one, this guy right here, very lateral guy. So the other two guys you need to know. This lateral guy you're going to be able to map out based on these other two guys. See, the other two guys are the ones you use for the dorsal column. They're your gracilis and fasciculatus guys for the arms and legs for proprioception. Right? So then this third one, that's your spinal lemniscus, which is for spinal thalamic tract. It uses the spinal lemniscus all the way up to your VPL, ventral posterior lateral nucleus, which then goes to the cortex and tells your brain you're feeling pain and temperature. It's a very easy line to draw. As you can see, it's literally just like that. That's it. All right, that's all you're really drawing. If you sit down on a piece of paper and you need to draw your spinal thalamic tract, you would just draw that. And what would you write? You would write that you use the spinal lemniscus. Where did the decussation occur? Ventral wide commissure. That's it. And it's a very simple thing. You need to simplify it. It's not simple in itself. Of course, nothing in neuro is simple. But you need to simplify it for yourself to be able to memorize it perfectly and reproduce it in your mind whenever you get a question regarding these things, this kind of anatomy. Right? Because if you ever get a question where they tell you there's a person with a lesion and it messed up this area over here and they're bleeding like crazy in that area, then you have to understand that that's going to take away the spinal lemniscus. They're not going to feel pain and temperature on that left side. Right, so that's all the spinal thalamic tract is. Very straightforward. Then you come to your dorsal column. So there's two different variations based off of whether you're using the gracilis, which is for the legs, or the cuneatus, right, fasciculus cuneatus, for the arms. Right, so that's the difference between the two drawings here. Generally speaking, otherwise it's all the same. So what does this guy do? So this guy, you sense the proprioception, and then it goes up from the spinal level, which is below T6, very critical level to keep in mind. It goes up from there, and then at some point it's going to make it into the medulla. Right? In the medulla, it's going to use whichever one of these two, depending on arm or leg. And right in the medulla, it's going to decussate. So it decussates in the medulla. Very important thing to keep in mind. Decussates in the medulla. Now, the gracilis and cuneatus are still the same name, so that's something that you always have to remember. Gracilis is for graceful legs. Cuneatus is for the arms. All right. So the gracilis in this image, the gracilis is decussating over, and it's going to use this structure right here, right? This weird structure right here that's sticking out, right? To now finally ascend all the way. Right, and what does this guy use? So spinal thalamic was using spinal lemniscus. Your dorsal column, which has the more medial of the dots, right, the more medial dots over here, uses the medial lemniscus. That's all you have to memorize. Right, so now if you were to do a quick sketch and draw out how your dorsal column ascends, you would literally just draw something like this. Right, so if I drew it in empty space, it would just be like this. That's it. And in your drawing, you would be visualizing that here it's using either the cuneatus or gracilis, depending on whether it's the arm or the legs, right? And then here, this is your medial lemniscus, the thing that was sticking out, right, from the brain, this segment, and then goes all the way up to the thalamus, right? Now, when it gets to the thalamus, it uses your VPL as well, right? Just like the other guy, VPL. Ventral posterior lateral. VPL. Remember that your VPL is your main guy for both of the ascending tracts going to the sensory cortex. We had a VPM as well. The VPM was medial. It was for M for makeup on the face. VPM was more of a facial thing. Right? And facial things are above the spinal column. So that's going to be a whole separate set of things you're going to need to know. Not the same as spinal column, right? This is spinal tract anatomy, spinal tract function, spinal tract lesions. That's not going to really do things to the face. The face has its own thing, because everything up here, as I said, you treat your entire head, brain, eye, ear, nose, tongue. All of that is its own full human body anatomy. It's a whole different thing. So getting these two down, not so bad at all. And then you have your last guy, the corticospinal tract, which only uses one key thing, and that's your pyramidal, where did I write it? Your pyramids and the internal capsule, right? So that's why I put this picture here, because it's really important to remember that the corticospinal tract is also just often called the pyramidal tract. And calling it the pyramidal tract is really nice, because then you'll remember that's where it decussates. So this is a descending tract, right? This is a tract where it's descending. Information is coming from your motor cortex, not the sensory cortex this time, the motor cortex, which is going to tell different parts of your body, depending on where the signal came from. It's going to tell you different parts of your body to move. So now this homunculus thing is a perfect example of why I say that the brain is an entire anatomy and body of its own. As you can tell, every part of the brain is working with an exact different part of the body. So it has its own anatomy, its own everything. Right? All of this segment is for the face, all of this segment is for the arm, and then right here in the medial section, this is for the leg. Right? So you can see all of these connections that are based off of what part of the body, what part of the brain is sending the signal. Right? This is what we use when we attach electrodes to people, and then we apply an electrical signal here, and it might make this guy's thumb move. Right? Or if I apply an electrical signal here, it might make his knee move, stuff like that. So okay, starts off. First things that you're going to get tested on is internal capsule strokes. Internal capsule. That's this white space. So they drew on the right side of the brain, right? This is the right side of the brain that's being drawn on. I'm going to draw on the left side of the brain. Yeah. So, because you always imagine these people are people looking at you, as you could tell, right? This guy is standing looking at you. So, this internal capsule is actually all this white space in between the things you're seeing here, in between these structures you're seeing here, which you need to have down perfectly, right? The thalamus, hypothalamus, the different little capsule areas over there. But the internal capsule is this white space right there. Now, what can often happen is people can get these lenticular striate artery strokes or lacunar strokes that mess up only the internal capsule and nothing else. So when that happens, in those people, in those questions, you're going to see that the only deficit they have is motor. Everything else is perfectly fine. All sensation is fine. They can feel pain. They can feel temperature. They can do their proprioception just fine. They have their balance just fine. Everything is good. It'll be a pure motor stroke. When you hear in any question, when you read the whole question and you realize that it's just a pure motor stroke, that's when you know that whatever happened to them messed up the internal capsule. They lost their internal capsule, which is why, of course, none of the motor signals are making it down, so they can't move anything. Now, if you don't have that issue, then of course you go down, you use the different parts that are being highlighted here. You don't have to memorize them per se. And then you have your pyramidal decussation. Now, the pyramidal decussation doesn't occur at a very specific place. It's in between different things, right? Like it's generally speaking, it's kind of sort of in between the midbrain and the medulla, in a sense, right? It finally makes it down here, does the pyramidal decussation. Now, there's a little complexity here and there, because you can see there's this lightly drawn signal that's also coming down. You don't need to worry about it too much. Your anterior corticospinal tract, don't worry about it too much. But the main one is this one, where it decussates, goes to the other side, and then now gives signals to either the arm or the leg, depending on how far down it had to go. That's the main lateral corticospinal tract. All right. So the decussation tells you that if we're ever really wondering, where the injury is, we're going to have a lot of confusion with these injury things, because injury on one side will either cause you to lose function on the same side or the opposite side. And the thing that it really depends on is, where did the injury occur? At what level did the injury occur? See, they've done a good job for the dorsal column image here, where they tell you that T6 is a big deal, right? And one of the best topics to look at to get a good grasp of this lesion thing, like where am I going to lose what kind of issue, we can use let me go to it, the disease of BronsonChord Syndrome. So BronsonChord Syndrome has these really weird losses that you're almost immediately going to catch in any question, because they'll do a good job explaining to you what the losses are in the patient. And when you see all the different weirdnesses of the losses that the patient is undergoing, you'll be like, this must be BronsonChord. So in these people, what happens is they have a hemisection injury. Half of the spinal cord is injured, which is what really messes up and makes this diagram so difficult. So you can see how only half of the spinal cord is injured, which means that things that are decussating on the other side and decussating and going up using that half are going to work fine. And also notice in this diagram that the arms are doing just fine, right? So they say, what are you going to lose? First of all, at the point where this is usually a bullet injury where someone got shot into half of their spinal column, at the point of the lesion, at the exact point of the lesion, you're going to have same side loss of all sensation at that lesion, and you're going to have same side lower motor neuron signs. Now, if you have any confusion between what is a lower motor neuron sign and what is an upper motor neuron sign, we'll come back to that. And then when you study this again, it'll make sense to you. But generally speaking, lower motor neuron signs mean everything is down. So your big toe won't be going up, flaccid paralysis rather than spastic paralysis, where you're actually flexing. Right? Everything is down. Everything is down in lower motor neuron signs. Upper motor neuron signs usually mean that the big toe goes up. That's a positive Babinski sign. And they usually have spastic paralysis where they're stiff. Right? So everything is generally going to be up in that one. That's a little memorization technique there. So at the side of the lesion, you're going to have lower motor neuron lesions, and you're going to have loss of all sensation. So you lose everything. You lose the dorsal column there, and you lose your spinothalamic tract there. So actually, to make this a little easier, let's actually grab and bring back the tracts. So let's go back up here. We'll grab our spinothalamic tract. Right here. And we'll just grab one of the dorsal column things. That should do the job. And put it right here. Okay. And then we can take a look at each one individually. So first of all, let's look at this one, right? So we have loss of all sensation. So look at how this is supposed to be going up, right? We're imagining, in this diagram, they're telling you that we kind of basically injured the right half of this person's spinal column. So the right half being injured fits perfectly with this diagram because thankfully in my drawing, it is the right half that we're using, right? So this dorsal column that I grabbed is coming from his right leg, because it's the gracilis. It's coming from the right leg, and then of course dorsal column doesn't decussate immediately, so it's supposed to go up first to the medulla, then decussate and do its thing. But since he's got the shot right here, he's going to lose sensation of course, any proprioception at that specific point. Okay. Then we also can look at this one real quick to grab the rest of what's going to happen. Similarly, since he's lost this half, right, any pain and temperature that he would be feeling at that exact location is also going to be cut off. Right? So at that exact location, you've cut off all sensation. It makes sense. It fits the diagram that we have. Perfect. Next thing is 3 and 4. Number 3, same side upper motor neuron signs below the level of lesion. Now, upper motor neuron signs are very obvious and easy to understand in the sense that you just think of a newborn. A newborn is supposed to have a positive Babinski sign. When you stroke the sole of their foot with a feather, their toe will go up. It occurs because they haven't fully developed the myelin sheaths and their neural plexus and everything perfectly. They're newborns. So when you have injury where you lost your nerves, it's almost equivalent to kind of being like a newborn where you don't have your nerves fully made. Right? So in this guy with the injury, you can assume that below the injury, they're going to have upper motor neuron signs because they lost their nerves here. Those nerves are kind of shattered now. Or in a sense, those nerves, the nerves that are coming from, let's say, like his ankle, it lost its connection here, so it can't make its connection all the way to the brain now. right? That lost connection is kind of like being a newborn who hasn't perfected the connections yet because they're still developing. So upper motor neuron signs. So now because of this injury, if I was to stroke this guy's right sole of the foot, his toe would go up and he's going to have spastic paralysis in that leg due to corticospinal tract damage. So now I didn't bring the corticospinal tract, but let's go grab that too. Let's go bring the corticospinal tract back onto this page as well. And that's this right here does the job. So if we put the corticospinal tract here now, we can see that since we have injured in this guy over here, that level that we're looking at is above the leg one, but below the arm one. So somewhere in between here, somewhere in between these two, there's another level, right, of the spinal column where this half has been injured. Now, unfortunately, this image that they gave, the image that I'm using, this is from Amboss. This is showing things that are coming from the left side of the patient. So if I was to quickly redraw how it would look for the right side, it would basically be a mirror image, right? So you would just be grabbing something from this leg, coming into here, right? And then basically going up like this, and then eventually having a decussation somewhere here, using this, coming all the way up, and then going to the brain. That's generally what you would see, right? Which is more relevant for us because, as I was saying, somewhere in between the arm and the leg, there's a spinal column level right there, maybe like T12, and the injury has occurred on this half. So, of course, any nerve coming from this leg all the way to the brain has been messed up. That's kind of what's happening here, right? So that takes care of that. Let's move this out of the way now. Okay, so that takes care of 3, and then number 4, impaired proprioception, light touch, and tactile sense. That's your dorsal column. So that's going to be this guy again. So impaired loss of dorsal column. So of course that makes sense because spinal level below T6, which is where the injury is occurring, as we're seeing in BronsonChord, you've lost any sensation below that too. Anything from any further down that's coming to the leg, anywhere further down coming to the leg using the gracilis, they're all messed up. No sensation. So if this guy closed his eye and then you moved his right leg to a certain location, or if you were trying to get him to do something with his right leg, he wouldn't know where that right leg is. Proprioception is my ability to know that exactly where my left hand is when I move it there with my eyes closed, because my brain has that tactile sensation. He's lost that tactile sensation. Right? And the vibration, light touch, and tactile sense, all of that is lost. He can't control where his right leg is, or he can't tell you where his right leg is. So in a sense, to further simplify BronsonChord syndrome, you can combine number 1 and 4 together. Then not only is there a loss of all sensation right there, but you also lose the same side dorsal column stuff as well. The only reason this becomes complex is because of the fact that the spinal thalamic tract is a little special. See, at this region, at this specific region, you lost your dorsal column and you lost your spinal thalamic. You lost both. Both of them are not working, so no pain or temperature, no proprioception. Below the lesion, though, it's different. And the reason for that difference is simply based off of what you would know about the tracts. The difference between the tracts is that spinal thalamic tract decussates immediately, whereas the dorsal column does not decussate immediately. It decussates a little higher up. So how is that affecting anything? Well, if we do this right here, we can see that the key difference, they've even written it in the diagram itself. The key difference is the level, the spinal level that we're supposed to be looking at. See, this thing occurred at below T6, which is true, right? T6 would be like somewhere over here. This is much further down. It's almost approaching the lumbar spines eventually. It's getting to the lumbar level very quickly. So right here, this injury messed up this But what happened to the spinothalamic tract? Why is the spinothalamic tract only affecting, or why is the only spinothalamic tract that you've lost on the other side? Well, here's why. Any spinothalamic tract stuff that was below the level of the lesion, let's say like, let me try to give it a number, like, why is it on the other side? So this is the right leg for the person. This is also the right leg for the person. Okay. At the level of the lesion, you lost it. If this one is that level, so let's say this is T12. This is T12 where the injury occurred. If this is T12 and this is T12, he lost everything there. So he lost any input of right side pain and temperature at that specific place. And it's never going to get a chance to decussate, because it's not going to decussate, it's not going to make it to the medulla, nothing, it's dead. It's severe, just like I've drawn it. But let's say that we go any lower. Let's say we go to L1. If this is now L1, in L1 over here, after getting a bullet shot there, in L1 this is still going to work fine, right? In L1 this is going to come over. Let me draw both. Let me also put right above it T12 where the injury is, right? So the injury is on this side, right? This half is all messed up. So if the injury is at T12, I'm going to label this T12, right? And we call this T12 too. Right, so the injury is at T12. If the injury is at T12, then in L1, pain and temperature coming from here, from this guy's left leg, is going to come, sorry, not left leg, excuse me, right leg. Any pain, not pain, yeah, pain, right? Is it? Yeah, pain and temperature. Any pain and temperature coming from the right leg at L1 is going to come just fine, decussate over, climb. You see, because there's no injury there. So the right leg, spinothalamic tract, is perfectly going to be fine, because it's going to use any of the lower places below the side of the lesion, right? It's going to come up to here, decussate immediately, and then go up. Decussation occurs immediately. That means that it decussates immediately as soon as it reaches the spinal column. For example, you have to understand that this was a little longer, right? It was a little longer. It got the sensation from whatever part of the leg. Right, so whatever part of the right leg, it got the sensation from the right leg, came up to the spine, then decussated immediately as soon as it reached the spine. So if it got the sensation from this right pinky, came all the way up to the spine, decussates immediately, then goes all the way to the brain. So you see how it's dodging this area of the injury. Same thing's going to keep happening. It's going to come all the way up here, decussate immediately, go up. Everything's going to be perfectly fine for the spinothalamic tract as far as the right leg is concerned. But imagine if the left leg was involved now. So at L1, that left leg, left pinky, that's going to come up to the spinal column, wherever. It could use any of these lower guys, L3, L2, whatever. It's going to decussate immediately, and then it's going to try to make its way up to the brain, and it's going to fail. It can't because of this injury. And this is why it's the left side that loses the spinothalamic tract sensation, right? Because of this immediate decussation that's supposed to occur. This is going to be true for any level the injury occurs at. So if this guy had initially an injury that wasn't at T12, maybe the injury was at a higher level of the spinal column, right up here. So he lost half of his spinal column at a higher level, maybe at this time actually at T6. T6 is a cutoff point. At T6, below T6, this decussation occurred. So if it occurred at T6, you're going to actually preserve a couple things, and at that point the question becomes much more complex. So you pray to God that that's not going to be your question. And always remember, if the injury ever occurred at some cervical level, then the person is just going to die. So that shouldn't even really be a question. Usually you're going to get questions where they'll tell you that the injury was at T7, T8, maybe T12, stuff like that. But no matter where the injury occurs, as far as the spinothalamic tract is involved, it decussated as soon as you reached your spinal column. As soon as it reached the spinal column, it decussated and went up. So no matter where the injury occurred, as long as it's messing up any half of your spinal column is messed up, you're going to lose the opposite side spinothalamic tract, because the spinothalamic tract, as we learned, decussates immediately. Right? So this BronsonChord syndrome, how do you make it simple? where you're going to be looking for a patient who has a bunch of shit messed up on the right side, but only one thing messed up on the other side, which is their spinothalamic tract. That's it. Nothing else. Nothing else is going to be wrong on the other side. So you can really make it very easy to catch in a question, right? No matter what happened to this person on this side, and remember this entire thing can be flipped to be opposite as well, right? So it could be that his injury occurred on this side, right? So then, of course, the story will still follow the same way, where his spinothalamic tract would all be gone on this side, right? So that's what you look for in a question. A person that got some kind of hemi lesion on the spinal cord and lost spinothalamic tract on the opposite side. But everything else that's messed up is on the same side. And that's the kind of complexity you want to have this down at, because it'll make things, like, that's the only way you're going to be able to answer questions. Right? This is basically the bulk of neuroanatomy. That's really all there is to it, because after this is all going to be the cranial nerves and the thalamus and hypothalamus, which are not really that much of a testable topic. This is where you get most of your testing on, because now you're going to see people, or see questions which are going to involve arteries, right? Vascular lesions, arteries that are getting messed up in the brain, and based off of which artery got messed up, you might have lost sensation, you might have lost your corticospinal tract, and you're going to have to figure that out, because they're going to give you lesions, right? So we'll get to the lesions. Before we get there, one last summary. So spinothalamic tract, how do you draw it? You just literally make a check mark, right? So it's literally just like that. That's it. And what's happening, what this is, this starting point right here, is the fact that now the signal has reached the spinal column. Of course, the signal came from further down. It came from all the way from your far right side pinky toe, right? All the way. That's the furthest place it's coming from, and it comes up all the way to all the way up your leg, reaches the spinal column, and then boom! As soon as it reaches the spinal column, it decussates. What does it use for the decussation? The white commissure. And once it moves over, what does it use to go all the way up? Spinal lemniscus. Very easy to remember spinal lemniscus, because it's the spinothalamic tract. So the only not so easy thing to remember is the ventral white commissure, which you do your best to memorize. Right? Ventral white commissure. All dorsal root ganglia stuff, because it's sensory. DRG, the DRG, dorsal root ganglia. Your dorsal root ganglia, everything in the dorsal aspect, these are all sensory, guys. Ventral root stuff is motor, right? This is a little med school level anatomy stuff that we learned when we were back in class. Right? This very few people learned in class. This stuff was not mastered very well in med schools. It's not really taught well in many med schools. And when it is taught well in any med school, it's usually the ones that are kind of robbing all your money. So it's tough like that, right? But this is what's happening there. So you got your spinothalamic tract. You can draw that down. Then you have your dorsal column. Pretty much only difference is, you know, your spinothalamic tract looks a lot like just this part right here, but dorsal column has it twice, right? So it's like a double check mark kind of thing going on, right? Where it came from whatever limb it was, it came from there to the spinal column, went up the spinal column on the same side, then it made it to the medulla and decussated. And in the medulla is using either gracilis or cuneatus, depending on which limb you're talking about. But again, very easy to draw. And when you need to draw this, the corticospinal tract, you go from up down, because it's a descending tract. You start from one side of the brain. You literally just draw a line coming all the way down, and then you decussate. And then you go to whatever limb. This point of the decussation is called the pyramidal decussation. It doesn't really have a very specific location that it occurs at, but it decussates using that pyramidal area, and then it goes to whatever muscle. What was the only critical parts here? It was the pyramid over here, and up here the internal capsule, which are these two guys, the internal capsule and the this thing. Right. So you have to be able to draw these guys. You have to be able to perfectly analyze these guys, and you need to see in these images, looking at this picture, right, and this level right here at the medulla, what often happens is you're going to get questions where there's been damage or a hemorrhage somewhere in the medulla. So we can see that here. So you see your medulla, you have injury A and injury B, right? So let's grab one of these guys and bring it over to see what's actually happening. So first we'll do this again. Let's get our spinal thalamic tract, put it right here. And if you look at it, so this is our spinal thalamic medulla right here, right? And if you really focus, then which of these two injuries, A or B, is actually messing up transmission of the spinal thalamic tract? Well, it's B, right? Because this is kind of encompassing, this segment is encompassing this segment, which means that the person with the B injury, hemorrhage in the B area, is going to lose spinal lemniscus, and that's going to cause loss of spinal thalamic, but on the other side, right? This is occurring on the left side of the brain, so this person is going to lose it on the right side of the arm or right side of the leg, depending on which level the injury occurred at. Where in the spine did the injury occur at? Right? If the spinal injury occurred below my arms, which it usually is, because remember how high your arms are. Your arms are kind of above or at the same exact level as where your spinal column starts. So almost all injuries to the spinal tract that involves injury to the spinal thalamic tract only causes you to lose pain and temperature in your legs. To lose pain and temperature in your arms, you would need syringomyelia, where the injury is in the cervical area, which is above your arms. When you have injury in the cervical area that stops your spinal thalamic tract from coming up, then you lose pain and temperature in the arms, right? And that's the key thing to keep in mind. No one loses pain and temperature in their arms. It's only syringomyelia. Pain and temperature in the arms cannot be lost. If you have a BronsonChord injury in the cervical area, which could cause you to lose pain and temperature, you also lose your life. The person's going to be dead, because that level injury would mess up everything, and that person's not going to make it. There's no way to repair that. They're going to die before they even make it to the hospital. Respiratory arrest, cardiac arrest, and they're not going to make it. So all spinal thalamic tract lesions that we really care about are usually going to be below the arm level stuff, below T6, below T7, and it's going to mess up things on the opposite side of the leg. So that's what we're seeing with injury B here, right? B is clearly involving that area. All right, so now let's go grab our other guy. We can get the dorsal column. So let's take this dorsal column right here. Now, if we look at the dorsal column, what gets injured here? So this is encompassing, if I draw it on the other side, well, no, I'll keep it on the same side. So this is encompassing still the same stuff. Doesn't look like it was really a part of it, you know. So for now, we can see that the dorsal column is more so involved in injury A. Injury A, which is encompassing this area, is messing up your decussation using this structure that's sticking out, right? That structure that's sticking out, as we spoke before, it was the medial lemniscus. Spinal lemniscus was spinal thalamic tract. Now we're looking at medial lemniscus for your medial things, the legs and the arms, right? In this specific image, the legs, the gracilis, which is the most medial one, right? So image damage A, that injury A over here, messes up your dorsal column. All right, not bad. Last thing to look at is your corticospinal tract, which I have right here. So let me just move it over. Oh, that didn't work. Okay, perfect. So now, looking at it like this, our level that we're concerned with is this one, okay? And because you can see the squiggly thing here, that's the squiggly thing right there, right? That's how I always identify that we're in the medulla. If they don't show you the squiggly thing, it'll be a little harder, but you should still be able to figure it out, because you'll still see your medial lemniscus, you'll see your spinal lemniscus, and the other guys, the gracilis and cuneatus and whatnot. So now, focusing on this again in the same way we looked at everything else, it seems that this injury A would be involved with your corticospinal tract, but on the other side. You see how this other side thing always plays a role? This is really annoying when it comes to neuroanatomy, because everything decussates in such different places. you need to know where the decussations occur and how the decussations occur for you to correctly pick what are going to be the results of various lesions. So in our guy, right, if it was this thing that was messed up, then yes, that would involve right here, which would cause the corticospinal tract to be involved too. So point is that lesion B mainly seems to be involving your spinothalamic tract. Lesion A seems to be involving your dorsal column and your corticospinal tract, because this thing is called the pyramid, as we discussed. Right, so the pyramid was used for your pyramidal decussation of the corticospinal tract. Your medial lemniscus, this guy, was used for the decussation of your dorsal columns, right? And then all the way over here you have your spinal tracts, which are your spinal lemniscus stuff for your spinothalamic tract. So if we look at the notes I've written here, A, injury A, left medial lemniscus is messed up for the dorsal columns, and the left pyramid is messed up for the corticospinal tract. Lesion of anterior gray spinal artery, like in medial medullary syndrome, patient will lose left dorsal column and corticospinal tract. So the patient will present with loss of right limb proprioception, right motor activity, and the left hypoglossal nerve itself. Because right here at the very top, this guy is your hypoglossal nucleus. They labeled it only on that side, so I'm showing you on this side. Right? There's a couple nuclei that often get involved. Your tongue. The deviation of the tongue is always a big deal. Right? So left hypoglossal nerve, this is all what you're going to see medial medullary syndrome is going to be about. Movement of the tongue, loss of proprioception, loss of motor activity. Right? Then you have injury B. Injury B is all the way out here. That's your left spinal lemniscus for the spinothalamic tract. And the lateral corticospinal tract gets involved sometimes too, because what you're seeing is this entire segment, the way this works. Remember, your corticospinal tract looked a little funky because of all the extra stuff it was doing. So it is kind of in that area too. Not just this area, but it's in that area too, depending on how you're moving things up. So when you come into this side of the brain, in the medulla, this area also often gets encompassed. Corticospinal tract injury is not exactly a giveaway for any kind of specific thing, so it gets involved in too many different places. So lesion of this thing, the more important thing was that you lost your spinothalamic tract, which was not involved in lesion A. So lesion B had your spinothalamic tract being involved, so that lesion is usually the PICA, right? Posterior inferior cerebellar artery not working because of a stroke, and that's your lateral medullary syndrome. The two big medullary syndromes you're going to be studying. Medullary because it's in the medulla. You're going to lose right limb pain and temperature, right motor activity, and you're going to lose your vagal nuclei. Because you have your, in this diagram, you have your nucleus ambiguous, right here. Right? And that nucleus ambiguous is one of the major nuclei of your vagus nerve. Right? Cranial nerve 10. See, they drew cranial nerve 10 for you here, too, in the medulla. Right? And it has its different nuclei. It has the solitary nucleus, it has the dorsal nucleus, and then it has the nucleus ambiguous. The three different nuclei of cranial nerve 10. Only the nucleus ambiguous usually gets involved in the injury involving area B. So these are things you're going to get questions on. These are the things that are going to happen when you're going to have patients having various lesions and you have to get it correct. Our point right now was to get a good understanding of how we're supposed to see this. How we're supposed to cast this. Because you could get an image like this, blank, with just answer choices like A, B, C, and D, and they're labeled all different parts of the medulla. And you're going to have to pick the correct part based off of how the patient is presenting. That's generally all that's going to involve. That was a big part of step 1, and it's something that's still going to be around in step 2. So that encompasses basically the big topic of your various different spinal tract functions. And here what we're seeing is exactly what we just spoke about, BronsonChord Syndrome, which has very varying different kinds of things occurring. This one is really cool. This specific image here shows you that they actually gave this guy an injury much higher. See, in the step 1 book where we were looking, our injury was somewhere over here. So a hemi section involving a very far down level of the spinal column. But in this specific image, they're causing an injury in C8. Right, C8. So what happened in this person? So they messed up this half of the C8. right? So they're showing you that the injury must have occurred somewhere over here, okay? Messed up half of his spinal column over there. The most immediate thing you can catch is that now that they're involving the neck, which is above the arm, see, C8 is above your shoulder, you've now officially lost spinal thalamic tract in your arm and your leg on the same side. Sorry, what am I saying? Excuse me. You've lost, not the red guys, lost your arm and leg spinal thalamic tract on the opposite side, because remember it decussates immediately, right? So loss of pain and temperature and the cruise sensation, contralateral, whatever, on the opposite side, right? All of it. This is the only image I've ever seen of BronsonChord involving a lesion much higher up. Although, unfortunately, this thing didn't come with a question, or I would have put it here. And I don't think it would ever come with a question that would do this, because this would be a dead person. Right? This would actually be a dead person. An injury that involved a hemisection lesion above the T levels in C8, that usually kills the person. Not usually, it always kills the person. It's a dead person. But for question purposes, I guess maybe they could toss this at you. And you should remember that you never lose spinal thalamic in the hand. But BronsonChord is nice, because what happens in BronsonChord is everything occurs on one side, except the spinal thalamic tract is the only thing on the opposite side. And the opposite side, because whatever was coming up, whatever, let's say I'm drawing a line for a nerve that was bringing spinal thalamic sensation from this leg, it would come up to the spinal column. Let me draw this correctly. It would come up to the spinal column and then decussate over and then try to go up, but you see there's a lesion, so the leg one didn't make it. Same thing for the arm would occur. It would come, what am I doing? Sorry. We're talking about the blue area. So it would come from this arm, right, get to the spinal column, decussate, and then try to make its way up, and neither of these signals are ever going to make it up, because it decussates immediately. And that's the issue with the spinal thalamic tract. It's a very weird thing that it does. It doesn't go up at all. It decussates as soon as the sensation reaches the spinal column. So injuries that you get with spinal thalamic tract are always going to be different from everything else, because everything else doesn't decussate immediately. Nothing else decussates immediately. It's only the spinal thalamic tract that decussates immediately. So to get that down one more time, this is a guy with Bronson-Chord syndrome with an injury at C8. Hemisection. Where is the injury? It's on the right side of the hemi lesion, the right hemi lesion, right side of the spinal column, at C8. So now what's going to happen, because it's all the way up there, which is above the level of your shoulders, above the level of your arms, any sensation coming from the leg came to the spinal column, crossed over, tried to go up, it's going to fail, gets cut off. Any sensation coming from the arm reaches the spinal column, decussates immediately, tries to go up, gets cut off. So now you're seeing loss of pain and temperature in both limbs, the arm and the leg, on the opposite side. On the same side is going to be the other guy, the dorsal column, and your loss of motor function, corticospinal tract. Same side. Because those guys don't decussate immediately. So they're supposed to come up from whatever side, and then they're just supposed to decussate later on in the medulla, right? The other guys decussate up here. Your corticospinal tract decussated up there, dorsal column decussated up there in the medulla, where the spinal thalamic tract actually decussates in your spinal column. Spinal thalamic tract decussates along the spine. It's very different from the others. So that's why most things that are involving the brain, if the lesion occurred outside of the brain, you see below in your actual body, below the neck, then it's going to be on the same side. If the lesion occurs in the brain, then those guys get decussated by the time they reach the medulla, so there's going to be contralateral injuries. So you're always going to have to wonder where the injury occurred based off of where the decussation occurred. If the injury is in the brain, it's going to be contralateral losses. But if the injury is in the spinal column, it's going to be same side losses, as far as the dorsal column and the corticospinal tract are involved. The spinal thalamic tract decussates on the spine, so that guy you talk about separately. The spinal thalamic tract does not decussate in the medulla, doesn't decussate in the brain. So BronsonChord is a perfect way of mastering and understanding how those decussations occur. you should always be able to draw what we just did earlier. Right? They're showing you here the spinal column. So the only other circle they're missing here is the medulla, right? Because that's the only other thing that matters to us. After the medulla would be your brain, the hypothalamus, or the ventral posterior lateral of the thalamus, right? VPL. So VPL. Okay, great. So if you need to draw things that involve this guy, right side lesion, doesn't matter. You can pick either arm and go ahead and do it. We could say we're going to pick this person's right side of the spinal column. So if we're going to draw all of our tracks onto this image now, then one we already saw. The spinal thalamic was the easiest one. Spinal thalamic from the right side would come here, decussate immediately, and then go up. And look at that. It's going to be perfectly fine. Right? This guy's right side, any spinal thalamic stuff is going to be perfectly fine. Then we draw the other thing. Now we can draw our dorsal column. So I just did the spinal thalamic. Now we could draw the dorsal column. The dorsal column would go all the way up, reach the medulla, then decussate, and then go up. Well, this just got messed up. Dorsal column's not going to make it, right? And then the last guy was your corticospinal tract. The corticospinal tract came down from above, right? So let's say we're going to involve this guy. Well, we'll keep doing everything on the same side. So now we'll still stay on the right side. So this is going to be where my muscular motion is going to get set into action. It's going to come down. It's going to do the all the way to here, do the medullary stuff, use the pyramid, and then try to go down, but it's going to fail because this is the C8 stuff right here. See, remember, if we go back to here real quick, see, this didn't decussate at the medulla, right? This was your medulla. It didn't do the decussation at the medulla. It came out of the medulla, and now it's entered your spinal stuff. This is the spine, right? It's entered here, but in a very weird location where it decussates. It didn't decussate before reaching the medulla like these other guys. These other guys decussated literally at the medulla. The decussate occurred for the dorsal column, not for the corticospinal tract. So your corticospinal tract is actually going to try to come down here, then it's going to try to go to that arm, and it's not going to work. It's also going to try to come down further and go to that leg, and that's also not going to work because it couldn't come down. Right, so this corticospinal tract drawing usually involves just a straight line as far as like test-wise, wherever it's concerned. And that's kind of how you get these things down. Once you have an understanding of where the lesion is, you should be able to draw the lines for the various tracts as necessary. Right, so corticospinal tract is the only little bit of a weirdness, but it doesn't matter because corticospinal tract doesn't give you the answer. It doesn't give you the answer. It's not going to break down what's happening. The only time corticospinal tract does give you the answer is if somebody had a pure motor stroke, which involves just the internal capsule. So they had a stroke right here somewhere, right, which only involves your internal capsule, so they only lose motor stuff. Everything else works fine. All right. So that's what this entire BronsonChord stuff is about. You want to make sure you're able to master this today, get it down. Outside of that, they then move on to spinal cord lesions. Lesions that are literally involving specific things, either due to infection, some kind of vascular injury, or some kind of an anatomical injury to that area. First thing they talk about is poliomyelitis. Now, poliomyelitis and spinal muscular atrophy, this is just something that's going to affect this specific little two things in here. We're looking at the spinal columns. We're not in the brain right now. When it affects just these two regions right there, and these will be labeled for you on your exam, when it affects those specific lesions right there, that will only lead to lower motor neuron lesions, which is caused by a destruction of the anterior horns. So, of course, lower motor neuron means everything is down, which also includes flaccid paralysis. So remember, paralysis can be two different types. You can be stiff, which is a spastic paralysis, or you could just be completely unable to move, so your limb has just fallen. That's a flaccid paralysis. That's a lower motor neuron lesion. That's a giveaway for spinal muscular atrophy, where you're not going to see any sensory issues. No sensory issues. Nothing else. It's just a muscular thing. Polio. All right. Then you have multiple sclerosis. Now, multiple sclerosis, remember the key thing for multiple sclerosis was that lesions were disseminated in space and time. Right. This was something that they love talking about. So you can clearly see it's all over the place. right? It's involving these two guys, and it's involving this little area here. Caused by demyelination, it's going to be random and asymmetric. White matter is only involved, not the gray matter stuff. Only the white matter is involved. Mostly cervical region, right? And then here we just talked about BronsonChord, hemisection, contralateral loss of pain and temperature, 1 to 2 levels below lesion, ipsilateral hemiparesis and diminished dorsal column sensation below level of lesion. Everything happens on the same side. The only thing on the opposite side is your pain and temperature. And the 1 to 2 levels is pretty key too, because you see how the lesion was at C8, but he lost sensation starting at T2. He will still retain sensation here in some places. Not sure why or how that works, but you could get weird questions where the answer choices may actually, put it like that. You got to pick it correctly. For example, for this question, the answer choice could be that this patient will lose sensation of pain and temperature at C8 on the opposite side. That would be the wrong answer choice. He wouldn't lose pain and temperature at C8 on the opposite side. It's a little lower than that, starting from T2. So really extremely technical kind of thing, a very asshole kind of answer choice that they put that for you, but hopefully it'll ring a bell, right? Then you have ALS, notorious, everyone in the world knows about it due to the ass bucket challenge, right? Amyotrophic lateral sclerosis. You could see it's involving the same thing as it involved here, but then it also involves the other guy. So what's the difference? The inside lesion is involving the gray matter, which was for motion, muscular. The outside lesion is involving the white matter, which is for mainly sensory. And remember what was over here. In this area, mainly what was over here was your spinal thalamic tract, right? So combined upper and lower motor neuron deficits with no sensory or oculomotor deficits. You're going to have both upper motor neuron and lower motor neuron signs, commonly presents as fasciculations with eventual atrophy and weakness of hands. Fatal riluzole treatment can kind of prolong survival, but you still end up dying. Commonly known as Lou Gehrig disease, named after the famous sports player, and that's generally all there is to it. Now, how do you catch this? So, even though this region right here involves the spinal thalamic tract, it doesn't involve the spinal lemniscus, and that's what you don't want to fall for. As long as it doesn't involve the spinal lemniscus, your spinal thalamic tract is going to work fine. So these people are the only other time where you get a patient who's presenting with pure motor issues, no sensory, no oculomotor, nothing else. Actually, there's a better description of this over here. Yeah, this page. So Lou Gehrig, there's a little more thing to remember. No sensory or bowel bladder deficits either. So they're going to tell you that in questions, right? Nothing else is wrong except for the fact that they can't do things that require their muscle. They can't swallow. They have a limb weakness. They get some fasciculations, atrophy. All of these are lower motor neuron signs. Upper motor neuron signs are going to be there with the emotional lability, spastic gait, spastic paralysis, clonus. All muscular issues, though. All muscular issues. They shouldn't have any issue of any sort that involves sensory stuff or bowel bladder deficits. This is very key. Then you immediately catch ALS, and you know this is involving the patient needing riluzole, but they're not going to make it. Last thing here is your posterior spinal artery and anterior spinal artery in this image, where you get complete occlusion of your anterior spinal artery, ASA. So in this diagram here, you can see this very nicely. You have your anterior spinal artery that supplies this anterior region, right? And then you have your posterior spinal arteries, two of them, that supply this posterior region. They've nicely labeled for you lateral corticospinal tract, right? And then over here, your spinal thalamic tract. And this is all in your spine. Remember, not the brain. This isn't the medulla. This is your spinal column. Right? We're looking at things that are in the spinal column, not the medulla. So when we're seeing the spinal column, right? This is what you want to memorize. This is what you want to have down every time you ever get an image of the spinal column. With you always know it's a spinal column when you find this butterfly. When you see the butterfly, you know you're in the spinal column. When you cast that, you should just immediately know this one, lateral corticospinal tract. And then this one here is spinal thalamic tract, right? And then of course in the back is your dorsal column with the same thing for your arm and leg, right? Arm and leg. The leg is more medial. So what's going to happen with your ASA injury? Well, ASA injury looks like it's encompassing pretty much everything for your corticospinal tract and your spinal thalamic tract. So it only spares the dorsal columns. Right? You're going to have a sensory motor dissociation, usually associated with abdominal aortic surgery. So you're going to get somebody with an abdominal aortic aneurysm or something, or aortic dissection, and then you're going to try to do surgery for it, try to help them out, and then boom, all of a sudden they present to you with loss of sensation, loss of motor ability, dorsal column is perfectly fine, ASA injury. They're showing you that here too, ASA injury or blockage to the artery. All right. Did they tell you what happens with the posterior spinal artery? They don't have that one here. Is that? Well, I guess, yeah, they don't really tell you what happens with the posterior spinal arteries though, because that one is mainly going to be very, so you can see that everything that got spared here is taken care of in tabes dorsalis, which was tertiary syphilis. Degeneration of the dorsal columns and roots, leading to just impaired sensation and proprioception, ataxia, poor coordination, but their corticospinal tract and their spinal thalamic tract are going to be just fine. Alright, so we're looking at the spine, just keep that in mind, not the medulla. This is all happening in your spinal column. Next one here is central cord syndrome. Central cord syndrome, you can see this really nice picture here, which is basically going to look just like your syringomyelia. Very similar to that. You have something that's messing up the anterior commissure, which is your white commissure, right? And it's going to involve just this, mainly this gray stuff, right? So weakness more pronounced in the upper extremities than the lower extremities, caused by hyperextension injuries in individuals over age 50. That's different from your actual syringomyelia, which is, I guess, talked about separately. I'm going to see it here. Oh, this one right here, excuse me. So let's take a look at the difference between the two, because you're going to get questions where you're going to have both answer choices. The biggest thing, if they give you enough data in the question, the biggest thing is going to be the fact that you can see how big the circle is here compared to the dot that you have here. Right? That's the number one difference. So because of the size of the circle, in syringomyelia, the only thing that was happening was you messed up the anterior white commissure. So your spinal thalamic tract sensation that came from the hand got here, decussated, and then was trying to go to the brain is going to fail. So your right hand won't be able to do it. Your left hand also won't be able to do it because it's supposed to come here, decussate immediately, then go up. And again, that point of decussation, the white commissure, is killed. As you can see, they put an X right there. This is bilateral. They're showing you one side. The other side would do the same thing as well, and that's not going to make it. It's not going to make it past that point. That's because they have a little syrinx here, this collection that's compressing the anterior white commissure. But nothing else. No weakness in muscle, no ataxia, nothing else. CSF-filled cavity with spinal cord expands and damages the anterior white commissure of the spinal thalamic tract. Can be due to trauma or tumors, seen in 35% of Chiari malformations. And you get this cape-like distribution of bilateral loss of pain and temperature. The cape looks just like this. But this guy not only has loss of pain and temperature, also has weakness. The weakness is because this injury, the circle went from here, the spinal thalamic tract was only that red dot. Now it became all of this, which is also encompassing some of your corticospinal tract, and that leads to weakness in the upper limbs more than the lower limbs, corticospinal tract. Alright, so that's the difference between central cord syndrome and syringomyelia. And then the last two things here, you have Corticospinal syndrome and vitamin B12. Vitamin B12 deficiency causes subacute combined degeneration, which is different from vitamin E deficiency. Right, so vitamin B12 deficiency patients, usually going to be the alcoholic patient. It's going to have demyelination of the dorsal column, demyelination of the lateral corticospinal tract. Remember, this is your corticospinal tract on the spinal column. And then spinal cerebellar tracts are going to get messed up, which is going to cause ataxia. Paresthesia, impaired position and vibration. The ataxia is due to the spinal cerebellar tract. Paresthesia and impaired position and all these sensation things are your dorsal column. Corticospinal tract getting messed up is going to cause them to not really be able to have much muscular movement. That's B12 deficiency. Corticospinal syndrome is compression of spinal roots L2 and below, Cauda equina is very similar to what's happening here in the syringomegalia, but it's happening at L2 or below. So you have a squeezing of nerves all the way down at the lumbar level, most likely caused by disc herniation. Right? So this is going to involve things like S4, S5, S6, sorry, S5, S4, S5 mainly, which we talked about earlier, and I'll go back and show you, regarding possibly getting all kinds of different sensory losses in the legs. So Cauda equina syndrome, although they don't talk much about it here at all, you have to know what is absent, what kind of reflex is absent. If it's an absent knee reflex, that's different from an absent ankle jerk reflex. All these reflexes that are missing are going to tell you exactly where the lesion is, not just a understanding of the basic area. No, you need to be able to figure out exactly where the lesion is. That we talked about when we finished up a little bit of the MSK chat from over here. Let me see if I can find that specific yeah, right here. Right, so of course any lumbar injury, lumbar compression, like they're showing you here, will cause lumbosacral radiculopathy. Right, so we're talking about below L2. So usually what's going to matter is L4, L5. Now, L4, L5, and then S1, not L6. So looking at these guys, you can perfectly master what's going to get messed up. First of all, understand that if it's a herniation of the L4 disc, when it comes out, it squeezes the L5 nerve as it's going up. Right? So the nerve being affected is the second number. So if the disc that came out is between L3 L4, it's going to come out and squeeze the L4 nerve. Okay, similarly here and here as well. Now, S1 is the easiest one. That's sciatica. Everyone describes it as a shooting sensation down the back of their leg, and it goes all the way there. Right? So since it's going down the back of the leg like that, and it's practically, the only main thing down back here is your Achilles tendon, these people have a decreased Achilles reflex. That's the reflex they lose. That's involvement of the tibial nerve. They're going to have weakness of plantar flexion. All right. And then over here, if it's an L3, L4 disc herniation, then you can see the way this is going. I wrote down that L4 affects the first toe. It goes to the big toe. So it actually goes past your knee. So these people have a decreased knee reflex, also known as a decreased patellar reflex. So when the question tells you there's an absent knee reflex, you know which nerve got compressed, L4. That's L4 for femoral. And you have to know all of that. The last one here, if it's between L4 and L5, it's going to compress the L5 nerve. L5 affects the fifth toe. Right? It's more lateral. It doesn't go over the knee. It goes all the way over here to your lateral stuff. It's a common peroneal nerve, which if it's injured, you're going to have weakness of dorsiflexion. And remember, there was the mnemonic of PED, PED, and TIP, TIP, where peroneal was for eversion and dorsiflexion, tibial was for inversion and plantar flexion. When peroneal or tibial is not working, you can't do the other whatever it's supposed to do. Right? So PED, TIP is the perfect way of remembering that. So if you get a patient who can't do plantar flexion, right? So weakness of plantar flexion, then that's going to be tibial nerve, because that's the P over here, PED, TIP. Inversion and plantar flexion, eversion and dorsiflexion. If you can't do your dorsiflexion, that's your peroneal nerve. If you can't do your knee thing, that's your femoral nerve. Very straightforward. Just, of course, you have to memorize it. It's not going to be commonsensically stuck to you, but you have to memorize it. That's going to be the stuff regarding Cauda equina syndrome. So you see, they just basic summary here. Very, very basic summary here. But that's not all there is to it. There's a lot more to it, just like we just talked about. So, get this stuff down, right? This is basically your today's, like in a sense, your today's homework or today's lesson. Getting this stuff down, getting an understanding of your drawings here for the spinal column, mastering this, understanding your spinal column anatomy, that this is corticospinal tract, this is your spinal thalamic tract, this back here is the dorsal column on the spine, and then in the medulla, it's, oh, wrong chapter. On the medulla, it's like this. The main images that we have labeled medulla, right, like that. And you need to know where things are in the medulla. So injuries occur in different places. Point is, by the end of today, you should be able to draw these lines. You should be able to draw the signal coming from whatever limb it's coming from, going to the spinal column, going up the spinal column, and then decussating in the medulla, and then making it all the way to the VPL. That's your dorsal column. Decussating immediately if it's spinal thalamic tract, and then how is your corticospinal tract come down? Look up videos if you need to. Look up more things on YouTube if you need to. These other things here, don't worry about. Those are extra. We'll come back to it at some other time. And then you'll eventually have a better and much stronger understanding of these things. And we'll continue tomorrow with what's next? Facial? Yeah. Alright, so facial nerve lesions and a bunch of practice questions to get stuff down. I'll keep jumping around more to get down more of the tying in of various lesions as we're going to see on questions. And then we'll just keep going until we have it down perfectly. Alright, thanks a lot, guys. Enjoy the rest of your day.